Welcome to Conversations on Healthcare. This week we welcome CMS Administrator Chiquita Brooks-LaSure on the President's health budget expanding support for mental health and community health centers. Now, here are your hosts Mark Maselli and Margaret Flinter.
CMS, 3 letters that make up an important acronym. For those in our audience who know what CMS stands for and does, we have the person in charge as our guest. And for those of you who don't know about CMS, stand by and learn the incredible impact this federal agency has on our entire U.S. healthcare system. It makes over $1 trillion in healthcare expenditures annually, and it's the largest healthcare payer in the entire country.
CMS, the Centers for Medicare and Medicaid Services, and Chiquita Brooks-LaSure is the agency's administrator. During the Obama years, she played a key role in guiding the Affordable Care Act through passage and implementation. Brooks-LaSure has decades of experience in the federal government, on Capitol Hill, and in private sector. And she's also the first Black woman to lead the agency. Welcome.
It's a pleasure to be here.
Oh, that's great. Administrator Brooks-LaSure, welcome again to Conversations on Healthcare. President Biden has just released his proposed budget for the next fiscal year. And of course, now Congress will weigh in. We know there are some important dollar amounts devoted to community health centers, mental health, HIV prevention, and other initiatives to support healthcare teams. I wonder if you could take our listeners through the budget and the thinking behind it.
So thank you so much for the question. We are so excited about this president's budget. As we all know, starting with mental health, the COVID-19 pandemic has just put such a strain on the mental health of Americans across the country. And all of us with children certainly know how much our nation's children have really suffered during this time period. Even those of means are having struggles, and certainly children who are in underserved communities are really at a crisis level. That's just the tip of the iceberg. And so as you hopefully are seeing, we have a department-wide focus on mental health, really looking across the entire, all of the agencies to really see what we can do. And I would say about CMS in particular, our focus has been and is going to be on the programs we serve. So as you mentioned, I like to say the 3 M's: Medicare, Medicaid, and CHIP, marketplace coverage. So we're asking Congress for additional authority in the Medicare program. We are going to, and you'll see from us, continued emphasis in Medicaid and CHIP, particularly around child health, pediatric care, and certainly in marketplace. So in commercial insurance, making sure that there's parity between mental health and physical health. So that's one piece that's a huge priority of the entire department, and certainly us at CMS. Another priority is nursing home care. And as part of the State of the Union, the president, we released along with us a charge to really look at our care in our nursing homes. And that's something that we release detail on, and our budget asks for additional dollars from Congress to make sure that we are able to really survey nursing homes and help them come into compliance with the rules that we want to make sure are in place so that our nation's seniors and people who are the most vulnerable are well taken care of. Those are 2 priorities. I'll mention our third, and then of course could talk more in depth. But as the president has outlined, health equity is a key priority of this administration, and we have all been working very hard to advance health equity across our programs and really work. I think a key part of our ability to address this is for CMS programs, the financing side, to really work with the other agencies. And so I'm really proud of the work that the agency is doing to really partner, whether with CDC, to partner with NIH, to partner with HRSA, to partner with all of the other SAMHSA, all the other organizations here to really try to move the needle on a whole host of issues like maternal health, like go on down the list. So that's really what this budget is really reflecting our work of trying to work together to address some of the most pressing healthcare issues facing our nation today.
Well, thank you for sharing those with us. Those are such critical issues to all of us who are engaged in healthcare and in the communities. We're seeing exactly what you're describing that you're trying to address. And I think we'll get to talk maybe a little bit about the health equity component a little bit later on. But I wonder if I could just get a question right up front that's very much on people's minds right now. Health and Human Service Secretary Becerra has extended the COVID public health emergency declaration until April, which is just right around the corner. We're all reading about the rise of the new Omicron subvariant BA2. And I wonder, having laid out your health worker vaccine mandate for the institutions and organizations and practices that you certify or are responsible for, how long do you think you're going to have to continue that health worker COVID vaccine mandate? We know the Republicans would like those orders to end right now, but what are your thoughts as you look at what's coming down the road for us?
Well, I would say a couple of things to that. I think that requirements often help people react and respond. And I would say what we have seen is that the response to the requirements has really lifted up institutions and workers following the requirements. We're seeing a great deal of compliance in nursing homes in particular. We're seeing booster rates and vaccination rates really growing. So I think that there was such a focus on what are going to be the hammers that we're going to use, but really what our approach has been to work with hospitals and all sorts of facilities to help them come into compliance. And I think it's working very, very well. To your larger question about how long are we going to be doing this, I think that people, the scientists and all of my colleagues over on the other side of the House are working really hard to try to make sure that we're responding to the science, to responding to what's happening. We, from our perspective, will be prepared for the public health emergency to end at some point. But we're, as you probably saw, we put out guidance to the states around when the public health emergency ends, not anticipating that it will end in April or X day or Y day, but really trying to make sure that everyone is prepared. And we will do the same for providers and others who are waiting for our guidance on some of the other emergencies that expire when the public health emergency ends.
You know, Administrator, I want to stay on the topic of the public health emergency. And CMS is asking states to explain how they'll handle eligibility and enrollment when Medicaid continuous coverage that began during the pandemic comes to an end. And as you know, there are nearly 85 million people enrolled in Medicaid, all who could suddenly have their eligibility redetermined. I think it's fair to say that this could result in many Americans losing coverage. And we're hearing that it's absolutely necessary for the Biden administration to hold states accountable for how they treat the most vulnerable in our healthcare system. I'm wondering if you can weigh in here on your thoughts.
Our entire agency is focused on what we call the great unwinding and we are very focused. And when I say the entire agency, I say that to say that we are very focused on making sure that we maintain the gains in coverage, whether people stay eligible for Medicaid or move to marketplace coverage or Medicare or commercial insurance. We are working very hard to make sure that we don't lose the gains that we have seen under the public health emergency. And that absolutely includes working with states. So our team that focuses on Medicaid is very closely monitoring and talking to states about how they're preparing and really trying to make sure that that we keep the gains that we've experience. That said, of course, states have the ability to make decisions. It's a shared responsibility between us. And so it's something that we have a close eye on. We're also working with state-based marketplaces, so the other side of the house, to make sure that we keep coverage. And you didn't ask me about it, but I would say a key part of holding on to the gains is really the subsidies that are in the American Rescue Plan, because what we saw during this open enrollment were real gains for the people who are right above that Medicaid level.
That's right.
And as we all know, that when a lot of our coverage, it's the leakiest between Medicaid and Marketplace. And so I think that's actually a big part of the story about how do we hold on to these coverage gains. Really having those subsidies makes a huge difference.
Great. Well, Administrator, I wonder if I can get another kind of specific question in that we're hearing a lot about, particularly maybe from the folks in our audience today in the community health center space, who are struggling with the nature of the good faith estimate that's part of the No Surprises Act. They already are managing sliding fee scale requirements and getting those details to patients. And they're asking if CMS is going to provide additional guidance to them about how to maybe manage and simplify all these rules. Anything you'd like to say about that?
So my favorite response during the Obama years was, "It's coming soon." So that's my answer. It's coming soon. You know, we definitely are hearing about the need for more clarification, and the team is working very hard to get out all of the additional guidance that's necessary.
Great. You know, each new administration makes changes, and we know CMS has been adjusting policies enacted by the Trump administration. You're stopping states from charging monthly premiums to newly eligible Medicaid enrollees, and I know Georgia has a lawsuit against CMS saying this change is, quote, an arbitrary bait and switch of unprecedented magnitude. Would you like to comment on the policy that you're trying to drive with these important changes?
Yeah, so broadly, I would say that the administration is firmly committed to making sure that we maintain the coverage of that people depend on. I mean, Medicaid is life-changing, life-saving. I had the privilege of being on a virtual call right when Missouri had expanded coverage, and got to hear from a woman who really was talking about her own experience of cancer and how this was changing her life, because now she was going to have coverage. I didn't go anywhere during my time in the Obama years without being thanked by someone saying how it had affected their lives, changed their lives in many respects. And so for Medicaid, we want to make sure, particularly during a pandemic, that people had access to affordable coverage. And so that's what we're doing. We're really encouraging states to expand. We're encouraging states to move in innovative ways. We need to make sure that people can afford that coverage.
Great. Well, Administrator, throughout these last couple of very difficult years, certainly health equity has been very much on the minds of all of us in healthcare, as I know. It has been on yours and the CMS Innovation Center, which looks to enhance healthcare quality and innovation, as the name suggests, has included advancing health equity as one of its key objectives. This would be a great time to tell us about this focus and what it exactly means. What is the CMS Innovation Center looking to do with this focus?
I'm so excited about our agenda at CMS. And I would say that the Innovation Center has a charge, and it's been focused on really trying to make sure we're thinking and testing models that will save costs and hopefully improve quality. And we are really, as part of our focus, the Innovation Center has had 10 years of experience. And what we're really trying to do is make sure that the person's experience is at the core of what the Innovation Center is doing and how we're thinking about it. And there's no more core thing to that, than making sure that we are improving health equity, and not that it's an afterthought, as I think it has been in so much of the discussion for many years. And so in the Innovation Center in particular, we're really trying to think about how do we bring in a stronger lens of making sure that the innovations are focused on the underserved. And by underserved, we've adopted a health equity definition for all of our programs at CMS, of really making sure that every individual has a fair and just opportunity, regardless of the list of things that can keep you from that, which can include race and sexual orientation and socioeconomic status and geography. We're really trying to make sure that our programs are actually working positively to advance health equity, not that we hope it's a byproduct. And so as part of that, we're including in our models a requirement on equity plans. How are you going to try to address underserved populations? In our latest announcement on ACO REACH, where we're actually going to pay a differential based on the entity's ability to move the needle on underserved populations. And that includes not just focusing on the people, but on the organizations like community health centers that serve the underserved. So that's a big piece of making sure that we achieve health equity. It's not just about making sure there are people of color, et cetera, included in our data and what have you. It's making sure people with cultural competency, organizations that actually are in the communities where people need to be served, are actually included in whatever innovative things we are doing. And so that's a big part of ACO REACH, of making sure we're also, as well as our broader strategy of really making sure we're thinking about the organizations that serve the people who we're concerned about achieving that optimal health outcome.
Well, the Center for Innovation is such a national treasure, and it's so good to hear that they're using the equity lens as they look at everything that they're doing. So we applaud their work. I want to talk a little bit about the ACO REACH program. The Biden administration has changed the direct contracting model after pushback from progressive lawmakers, but the House Progressive Caucus still wants to get rid of it, now known as ACO REACH. What do you say about their criticism that this accountable care organization model just adds an unneeded middleman?
Well, I think that pulling back and really looking at what's happening in the Medicare program is really important, that we put all of our initiatives in context, which we are really trying to do. And I would say that when you look at what's happening in the Medicare program overall, Medicare Advantage is growing, and it is able to provide some services that we want to make sure that people who enroll in traditional Medicare are able to receive. And one big piece of that is coordinating care, where we want to see entities have an incentive to make sure that we're looking at the whole person. And so as part of some of the changes that we made with ACO REACH, we really wanted to make sure that a provider perspective was stronger in the ACO REACH. So having more providers as part of the decision-making process was a big part of some of the things that we want to do. But I would say that we look at models like accountable care organizations, and we've learned from, we have models in different parts of the program that when done well can really make a difference in terms of people's lives. And so we want to make sure that we're preserving some of those important elements and really building on those.
Well, Administrator, it's hard to talk about healthcare without talking about money, of course, in our country. But one of the areas that has never, maybe quite made sense to everybody as anything more than maybe historical accident is the difference in the payment schedules for Medicaid and Medicare. A physician providing the exact same service to somebody covered under Medicare or Medicaid has possibly very significant different payments. The work of nurse practitioners for the last couple of decades has been reimbursed at 85% of the physician pay schedule for the same service, even as we emphasize team-based care and multidisciplinary teams. What are your thoughts about approaching some of these long-standing inequities, if you will, in the payment system? Is that part of the charge to the organization at this point, or part of your initiatives?
Yes, I would say these sometimes, a lot of the team, they would often hear from me, how much of this is in the law? How much of this is how we've done it? And really trying to tease out what do we have authority for, and what can we do under our own authority. I think a couple of pieces to the question you asked. I do think that we as an agency are really focused on making sure that Medicaid is meaningful coverage. So whether it's Medicare or any of the other M's, we want it not to be a card in your pocket, but really make sure that it means you can see your doctor. And as part of that, we have a Medicaid access request for information, where we're really looking at making sure that we are talking and understanding what's happening in the Medicaid program in terms of people getting adequate access to care, whether it's making sure the benefits are there or making sure the providers. So I think that's one piece. And certainly in the Medicare program, we will continue to look at what our levers are. We recently, in our physician fee schedule, included an update that's going to integrate more information about a variety of ways that people get paid. That's the first update of in 20 years of including some of this additional information. So we are certainly looking at what our levers are and thinking about ways that we can try to address payment, of course, as appropriate, balancing that with what our statutory authority is and being good stewards of the trust funds.
Well, I want to pull the thread on what we can do on our own authority, or what's required under the law, and particularly on the issue of graduate medical education payments, which fall under CMS. And the recent National Academies of Science, Engineering, and Medicine report on primary care highlighted the need for the use of interprofessional teams. And I'm wondering, can CMS make changes to those graduate medical payments? Right now, we can only pay for the physicians and the dentist. How about the rest of the team? Is this an idea that is within your purview, or does it require legislative action?
So the team isn't sitting with me, but they would kick me under the chair if they were, to say, don't you dare commit to anything in public. So I will have to say that I will look into it. I will say that we have, when it comes to GME, a lot of statutory requirements. We do pay hospitals, and that's usually our lever. But happy to look at some of these ideas and see if there are things that we can do.
Well, perhaps then I'm going to rephrase my next question, or they'll be coming and kicking you under the table if I ask you about reimbursement for community health workers. But I'm really at least as interested in asking you about your thoughts on this. The community health workers, probably a group that maybe wasn't so much on the radar of CMS until we started moving much more in the direction of moving the needle on outcomes, on value-based plans, on the community engagement. What's your thought on where community health workers fit into the kind of Medicare, Medicaid family at this point?
I would say, I think, just as you said, there's sort of new understanding of how important the community is to delivering health outcomes. And from my own perspective, I think I really got more of a perspective on that right before I ended up being CMS Administrator, of really trying to work on some of these issues like maternal health, like equity, where you really do need the village to help. And then, of course, I think we all got an education when it came to COVID-19 of just hearing about people need to hear from trusted partners. And a lot of times those trusted partners are people in their communities, or they need the help from the doula or the person that connects them to the other supports. And just how health is one and probably one of the biggest determinants of how you are going to be able to live your best life and pursue happiness. But just how integrated all of that is. So we are certainly looking at ways that we can integrate community health workers into our payment processes. So whether it's through the Innovation Center of looking, and through the Innovation Center, we have been able to have more flexibility, and we will continue to look at our ability to do that in Medicare. And certainly in Medicaid, states have flexibility to do those things. And we recently approved a waiver in California that went further in terms of allowing some of those supports. And certainly we'll look at other state initiatives as well.
Great. Well, thank you, Administrator Brooks-LaSure, for these insights. And thanks to our audience for joining us for this talk about healthcare, how it's paid for, and all of the issues wrapped up in these decisions. You can learn more about Conversations on Healthcare and sign up for our email address at chcradio.com. Again, Administrator, thank you for all the work you have done over a lifetime, and we appreciate you taking time with us today.
So glad you had me. Have a great day.
All right, you as well.
Thanks so much. Best of luck.
Thank you.